Hello, and welcome to today's webinar. The Facial Paralysis and Bell's Palsy Foundation presents Congenital Facial Paralysis with Dr. Bryn Webb. I'm Lisa McKinley, Director of our foundation. I thank you for joining us for this seminar. I'm being assisted today by my Portland Support Group leader, Barbara Pasternacki. Dr. Webb's presentation today should last approximately 45 minutes, followed by a 15-minute question and answer period. If you would like to ask a question of Dr. Webb, then please type it under the questions section on the taskbar you're seeing on the right side of your screen at any time during the session. We will present the questions to Dr. Webb at the end of the session, and she will answer as many as time allows. I would now like to introduce you to our speaker today. Dr. Bryn Webb is a geneticist and physician scientist in the Department of Genetics and Genomic Sciences and Pediatrics at the Icahn School of Medicine at Mount Sinai in New York City. Dr. Webb both evaluates patients and actively engages in scientific research in her own research laboratory. Dr. Webb has a clinical and research interest in the genetics of birth defects, and she has investigated the genetic causes of congenital facial paralysis for the past 5 years. Dr. Webb, I'd now like to turn this presentation over to you, and thank you for being here today.
So thank you very much, Lisa, for your kind introduction and invitation. It is my pleasure to be able to speak with you today and review what is currently known about the genetics of congenital facial paralysis. As Lisa mentioned, I'm a pediatrician and clinical geneticist at the Icahn School of Medicine at Mount Sinai, and I became focused on the genetics of congenital facial paralysis during my fellowship training, and I've now been studying this condition for the past 5 years. So I just wanted to share a couple of photos first of the Icahn School of Medicine in Mount Sinai, just so that you can get an idea of where I'm located. So we're here in New York City, and this is our hospital complex, and we're right here on the Upper East Side, adjacent to Central Park. And right here is the Icahn building. My lab and my office are in this building. So to get started, I'd like to begin with a few definitions. So facial nerve paralysis is defined as the loss of voluntary movement of the muscles of the face due to abnormal function of the facial nerve. The facial nerve is also known as cranial nerve 7. The term congenital facial paralysis refers to the occurrence of facial paralysis that has been present since birth. Congenital facial paralysis, or CFP, may be divided into 2 subgroups, acquired or developmental forms. Acquired congenital facial paralysis occurs at birth, generally resulting from trauma. And this can occur with either a forceps delivery or due to pressure from the sacral prominence on the fetal face during labor. Acquired congenital facial paralysis is most often temporary. Acquired congenital facial paralysis is in contrast to developmental congenital facial paralysis, which results from an abnormality during fetal development. Most often, developmental congenital facial paralysis is permanent. Epidemiology. So congenital facial paralysis is estimated to occur in 1.4% of live births. The majority of these cases, however, are acquired congenital facial paralysis secondary to birth trauma. Developmental congenital facial paralysis is rare, and the true incidence is difficult to determine. There are no known racial, geographic, or gender-based predilections for congenital facial paralysis. So what are the signs and symptoms of congenital facial paralysis or facial weakness? I.e., what exactly are we talking about? So the most noticed symptom is generally an asymmetric or absent smile. Sometimes affected persons are described as having a mask-like faces. Other symptoms may include decreased forehead movement, sagging of the eyebrows, inability to close the eye, disappearance of the nasolabial folds, and these are the folds, the skin folds that run from the side of the nose to the corners of the mouth, and drawing of the mouth to the unaffected side if it's unilateral or one-sided. To assess facial weakness on a physical exam, physicians may ask affected patients to close the eyes, elevate the brow, frown, show the teeth, pucker the lips, and tense the soft tissues of the neck. So what is the facial nerve and how does it develop? So the facial nerve, or cranial nerve 7, is formed early during human development in a region of the brain known as the hindbrain, or rhombencephalon. So by 26 days in gestation in humans, the hindbrain is partitioned via periodic swellings into 8 compartments called rhombomeres. So here on the right is a picture of the rhombencephalon depicted in mouse, but mouse is very similar to that in human, and mouse is obviously more easily to study and to assess the anatomy. And so these units are the individual rhombomeres. And so as you can see, cranial nerve 7 motor neurons are generated in rhombomere 4, right here. And the axons migrate caudally from R4, adjacent to the foreplate, into rhombomere 5 and rhombomere 6. At the same time, the motor neuron growth cones migrate dorsolaterally towards their exit point in rhombomere 4. And just a note, cranial nerve 6 develops here in rhombomere 5, and that's important for Moebius syndrome, which is a type of congenital facial paralysis syndrome, and I'll be speaking further about later. So anatomy. The hindbrain, or rhombencephalon, becomes the medulla, pons, and cerebellum when the brain is fully developed. So the facial nerve emerges at the lower border of the pons and has a complex anatomy, as can be seen in the figure on the right. And incredibly, this drawing was made in 1918 by an anatomist named Dr. Henry Gray. So the facial nerve has sensory and motor components. The motor components include movement of the facial musculature and innervation of the stapedius in the inner ear. So the stapedius is a tiny muscle in the inner ear that contracts to dampen down the transmission of loud and potentially harmful sounds to the eardrum by reducing the oscillation of the ossicles. So if this portion of the nerve is damaged, patients may be sensitive to loud noises, and the symptoms termed hyperacusis. The sensory components of the nerve include providing taste to the anterior 2/3 of the tongue and feeling to the skin around the ear. The nerve also has parasympathetic fibers that innervate the lacrimal, sublingual, and submandibular glands. Anatomical localization of the lesion. So facial weakness may be due to lesions at various anatomical locations, including upper motor neuron lesions, which are lesions in the motor cortex, subcortex, or corticobulbar tracts. And this is most often the case, or the cause of facial weakness due to vascular events in adult patients, such as when there's a stroke, and so not necessarily common in congenital facial paralysis. Another anatomical lesion is aplasia or hypoplasia of the cranial nerve nuclei that develop in the hindbrain. And this may be associated with an ipsilateral cranial nerve 6 palsy. Again, cranial nerve 6 develops adjacent to cranial nerve 7 in the rhombencephalon. So patients with this will have inability to move the eye outwards. We'll talk about that a little bit more later. Another anatomical location is a peripheral nerve abnormality. These could include either aplasia or hypoplasia of the nerve, so a malformed nerve itself, or an aberrant course of the nerve. And another anatomical location lesion could be that it's primarily a muscle problem or myopathy, meaning that the nerve may function, but facial weakness may develop because of weakness or aberration in the muscle itself. Exam findings can sometimes be helpful in the localization of lesion. For example, sparing of the forehead muscles is suggestive of an upper motor neuron lesion, although a peripheral nerve problem cannot always be excluded in some of these cases. So what are the etiologies of congenital facial weakness? Well, environmental and genetic causes have been proposed. Regarding environmental causes, there are 2 points that I'd like to discuss. A vascular theory for facial weakness has been proposed by multiple authors or investigators. And basically the thought here is that if the blood supply that supplies the tissues of the hindbrain where the facial nerve is developing is disrupted, this could lead to facial paralysis. So in that area of the hindbrain, there are paired arteries that form the basilar artery at 32 to 34 days in human gestation, and the vertebral artery, which will supply the basal artery, develops between 37 and 40 days in human gestation. And these 2 arteries are seen on the right. Here is the basilar and the vertebral arteries. So support for the vascular hypothesis is suggested by the fact that Moebius syndrome, which is a congenital facial paralysis condition with also cranial nerve 6 involvement or ocular involvement, and Poland anomaly, which is a condition where the chest wall fails to form. So it's a chest malformation where the muscle of the pectoralis major in the chest doesn't fully develop. So support for the vascular hypothesis is due to the fact that both Moebius syndrome and Poland anomaly have been seen to occur together and not infrequently. And it's been suggested that an occlusion at the level of the subclavian artery, which is seen right here, which would also disrupt then the vertebral and the basilar arteries, could be causative for a malformation of both the chest wall, Poland anomaly, and Moebius syndrome. Additionally, specific teratogens have been known to cause congenital facial paralysis. Particularly the drug misoprostol has been associated with Moebius syndrome. This drug is often used in the developing world as an abortion agent. So in pregnant women who have taken misoprostol but have failed to have an abortion, there's an increased incidence of Moebius syndrome that's been reported by multiple authors. So this drug is a synthetic prostaglandin that functions to cause premature uterine contraction, and thus the etiology of Moebius syndrome in these cases is thought to be due to vascular insufficiency. Similarly, cocaine use during pregnancy has been associated with Moebius syndrome and also thought to arise via mechanisms of vascular disruption. So teratogenic effects may be dependent on dosage and timing of exposure. So the critical time period has been suggested to be between 6 and 8 weeks. So those are some of the environmental causes. So what do we know about genetic factors? Or what's the evidence for genetic role in congenital facial paralysis? Well, congenital facial paralysis has been reported to cluster in some families, meaning that some families have multiple affected persons. So on the bottom, there's a picture of 2 pedigrees and basically how we represent this family information. And so here a circle represents a woman, a square represents a male, and persons who are affected with the condition are filled in or shaded in. So these persons would be affected and this person's unaffected. And so these are parents and these are children. So here on the left, we can see very simplistically a pedigree that's showing likely a dominant trait because parents and a child are affected. This is in contrast to what we call a recessive trait, again very simplistically, but in this sort of setup, the parents are unaffected and a child is affected, and there can be multiple siblings who are affected, but the key is that there's no parent-to-child transmission. So congenital facial paralysis is thought to be genetic because of that evidence of multiple persons affected in certain families, including either dominant pedigrees or recessive pedigrees. Another thought that congenital facial paralysis is genetic is because the facial paralysis is often associated with different features and that combination of symptoms can be seen frequently and thus be representative of different genetic syndromes. So different constellation of features are seen more frequently than what you would think by chance alone. Additionally, we have direct evidence of genetic factors in some cases because in some presentations we know the disease causing genetic change. So congenital facial paralysis and a genetics evaluation. So I'd highly recommend that all persons with congenital facial paralysis be evaluated by a clinical geneticist. And so this is a cartoon illustrating what our genetic material is. So in our bodies, we are composed of about 100 trillion cells, and in each of our cells, there's a structure called a nucleus that contains the genetic information. And that genetic information is arranged in structures called chromosomes, and when that information is stretched out at length, we can see the DNA or double helix structure. So our genome, which is the genetic material in our cells, contains about 25,000 genes. And these genes are the instructions for proteins that are the building blocks of all of our cells. So what does a clinical geneticist do during an evaluation? So the evaluation begins with a complete history and then a complete physical examination. So for the evaluation of a person with congenital facial paralysis, the geneticist will pay special attention to the prenatal history, the labor history, the age of onset, and the presence of other major medical problems. On physical exam, the geneticist will also look to see if the facial paralysis is unilateral or bilateral, meaning on one or both sides, the degree of the severity, and the presence of associated symptoms, which may lead to the diagnosis of a particular syndrome. So the main assessment is generally assessing whether the facial paralysis is either isolated, meaning not occurring with other symptoms, or associated with other symptoms, which is termed syndromic. For all persons with congenital facial paralysis, I would recommend general genetic screening, which generally includes both a chromosomal analysis and a chromosomal microarray. And I'll speak more about these tests in the next slide. Additional tests may be recommended based on history and assessment, including specific gene testing if indicated, hearing exam if indicated, and imaging studies if indicated. So what is a chromosome analysis or a chromosomal microarray? So chromosome analysis is also termed a karyotype, and this test evaluates the number and structure of a person's chromosomes. So on the picture of the right, you can see a typical karyotype, and we have 46 chromosomes, and 23 of these are autosomes, and the 23 pairs, and the last pairs are sex chromosomes, so here is an X and a Y. And so we can see here a normal male karyotype. So although rare, there have been reports of specific chromosomal translocations and other aberrations that have been reported as associated with certain types of congenital facial paralysis. The next test is called the chromosomal microarray, and this is a newer test, a newer technology, and it identifies submicroscopic changes in the amounts of genetic material. And these changes are termed copy number variation, or CNV. And again, although rare, specific CNVs or copy number variants have been reported in cases with congenital facial paralysis. For example, a microdeletion containing a particular gene termed neurog1, which is also a known candidate gene for facial paralysis due to animal model studies. So a patient with an atypical Moebius syndrome was found to have a microdeletion containing that gene. So what are some of the clinical syndromes that are associated with congenital facial paralysis? The answer is, well, there are many, but I'll be speaking today briefly about some of the more common conditions that we consider in the work of a person with congenital facial paralysis. And so those include Moebius syndrome related disorders, including disorders caused by changes in HOXB1 or TEB3, 2 different genes. Also CHARGE syndrome, and another condition that's a spectrum of disorder from hemifacial microsomia to oculo-auriculo-vertebral spectrum to Goldenhar syndrome. Another condition called Faciloscapulohumeral dystrophy. And lastly, I'll speak briefly about asymmetric crying facies. So Moebius syndrome. So Moebius syndrome is one of the more well-known syndromes that include congenital facial paralysis. And it was eponymously named for a German neurologist, Dr. Paul Julius Moebius, who reported features of this condition in 1888. And so here on the right is a picture of Dr. Moebius. And so the exact definition of Moebius syndrome, it's been defined by a clinical group here in the U.S. at the 2007 Moebius Syndrome Foundation as congenital non-progressive facial weakness, so congenital facial paralysis, in addition with limited abduction of one or both eyes. So what that means is, our eyes have the ability to move in all different directions, and abduction means when the eye moves outwards or away from the nose. So, Moebius syndrome is facial paralysis plus either one or both of the eyes not being able to move outwards or away from the nose. So Moebius syndrome is defined by the presence of those 2 features, but it may also include associated features such as muscular hypotonia or low muscle tone, developmental delay or intellectual disability, autism, other cranial nerve involvement, commonly hearing loss or limb malformations, especially clubfoot, or limb reduction defects, and heart defects. So the incidence of Moebius syndrome is roughly 2 to 20 cases per million births. And familial cases have been reported, cases where there's multiple persons affected in a single family. And for the majority of cases, the etiology is currently poorly understood. So Moebius syndrome-related condition HOXB1. So our group at Mount Sinai, in collaboration with Dr. Elizabeth Engel's group at Harvard, identified changes in a gene called HOXB1 in some patients with congenital facial paralysis. So here in the figure you can see these are 2 separate families with who are found to have changes in HOXB1 and have this HOXB1 condition. In A we see 2 brothers, 2 siblings with the condition, and in F we see also 2 siblings with the condition, just one's an older photograph. And so what you can see here in A is both boys have bilateral facial weakness, and you can see in this picture, especially in the younger boy, he has what we call strabismus, meaning misalignment of the eyes. The eyes aren't looking perfectly straight, at rest. So originally they were misdiagnosed as having Moebius syndrome because it looks like this right eye maybe has the inability to move outwards. But actually, when we did full ocular motility testing, you can see that this boy is able, when he's asked to look towards the left, he's able to look towards the left, and when he's asked to look towards the right, he's able to look towards the right. So he actually has full ocular motility. So even though he has strabismus, he has this full ocular motility and thus does not meet the classic definition of Moebius syndrome. So the panels in CDE are MRI images, and these images, the facial nerves were not identified at their expected locations nearby the vestibulocochlear nerves, which are marked with arrows. And again, panel F is just showing a second family who's also affected. And so this condition has now been termed in OMIM, which is our database by geneticists of naming different conditions, as hereditary congenital facial paresis type 3. And the change we identified in these individuals was the R207C change. So at a particular amino acid are the building blocks of a protein. So at position number 207, one amino acid, arginine, was changed to cysteine. And so here's a figure basically showing that change. So here is a cartoon modeling the structure of the DNA and the assembly of the protein. And you can see that the arginine 207 is in a position of the protein called the homeodomain. And when we're often considering different variants, we often look to see if that particular amino acid, if it's conserved in multiple species, because that would mean that most likely that amino acid has an important function. So you can see here that that particular arginine was conserved through mouse, through dog, etc., chicken. And then in other types of homeodomain containing proteins in that position in the homeodomain, that arginine is also highly conserved. You can see right here. So in these panels, this is a picture showing modeling of the protein change. And here we can see normally that the arginine 5 is important for binding of DNA. And here's a zoomed in view where the arginine, that's the regular or the common amino acid at the position, normally forms 3 hydrogen bonds here with the base, so it strongly is able to bind a base. And here, what we saw is that when we modeled the arginine to cysteine change, which is the mutation in these persons, that they were able to only bind with 1 hydrogen bond. It was a less stable interaction. So HOXB1 is a recessive condition, meaning that it takes 2 copies of a mutation to give disease. So for every gene in our body, we have 2 copies, one that comes from mom, one comes from dad. This is recessive, so again, it takes 2 copies to give symptoms. And parents are typically unaffected in their carriers. They have 1 copy of the change. So another Moebius syndrome-related condition is TUB3. And this condition was identified by Dr. Elizabeth Engel's group at Harvard, and there's been a couple of publications. And we've been fortunate to also work with her a little bit on this condition. And what Dr. Engel's group found is that the E14K change, which is a glutamate to a lysine change in the gene TUB3, which is a tubulin protein, this change is associated with congenital fibrosis of extraocular muscles type 3A, ptosis, which means droopy eyelids, and facial weakness and developmental delay. So below are some pictures of some persons who are identified with the TUB3 E14K syndrome, and you can see notably the droopiness of the eyelids in addition to the facial paralysis. This condition is autosomal dominant, meaning it only takes 1 copy of the change to give symptoms, but typically this change is not inherited. So the change occurs new in the person who's affected. So early on, after conception, after a sperm and egg meet, there's a change, a mutation, and then the person gets these features. And so this is now known as TUB3 E14K syndrome. So another condition commonly associated with facial paralysis is CHARD syndrome, which is caused by mutations in the gene CHD7. And so CHD7 is a transcription factor, meaning it's a protein that also binds DNA. And CHD7 stands for chromodomain helicase DNA binding protein 7. And so this family of proteins functions in the organization of chromatin. And this is also an autosomal dominant disorder, meaning it only takes 1 copy of a change to give symptoms. And CHARD is an acronym for coloboma, heart defects, choanal atresia, retarded growth and development, genital abnormalities, and ear anomalies. So a coloboma pictured here is an iris coloboma, and you can see like a keyhole defect. But basically a coloboma is an eye abnormality present at birth, and it's a defect or missing tissue in the iris, retina, choroid, or optic disc. And this occurs in about 80 to 90% of those known to have CHARD syndrome. Congenital heart disease is also common, 75 to 85%. And choanal atresia means when there's a blockage in the back of the nasal passageway or choanae, and that occurs within about 50 to 60%. Again, retarded growth and development and genital abnormalities can occur, and then ear anomalies are very common, and they occur in about 90%. And sometimes it's been reported that persons with CHARD syndrome have like a typical charged ear, which I'm showing here. You can see it's a little bit of unusual morphology to the ear with an unusual interior configuration. So, but about 40% of persons with Char syndrome also have facial palsy, and that's why we're talking about it here. Cleft palate and dysphagia or trouble swallowing is also commonly associated, and the incidence is at least 1 in 10,000 births. So hemifacial microsomia or oculo-auriculo-vertebral spectrum or Goldenhar syndrome, these are all terms for different degrees of the same condition. So hemifacial microsomia is a condition where the lower half of one side of the face does not grow and properly develop, typically leading to facial asymmetry. And I'll show you a picture on the next slide. So Goldenhar syndrome is the term used for the more severe end of the spectrum, and it's usually associated with additional anomalies, including abnormalities of the vertebra, heart, and kidneys. So commonly, in addition to the facial asymmetry, OAV is known for ear anomalies, and those can be as mild as just preauricular tags, which are just extra pieces of skin in front of the ear, or as severe as microtia or anotia, which means, anotia means without ear, microtia means small ear, but I'll show you a picture on the next slide, but it's basically failure of the ear to develop. An eye finding that's classic for Goldenhar syndrome or the spectrum is epibulbar dermoids. But 10 to 45% of patients have facial nerve palsy. Again, it's different numbers based on different persons reporting, but a good few people have facial paralysis in this condition. And the frequency is approximately 1 in 3,000 to 1 in 5,000 cases, and for the majority of cases, the etiology is currently poorly understood. So here's some pictures of persons with Goldenhar or OAV spectrum. You can see clearly here the facial asymmetry. This side of the face is much more full than her right side of her face. And here on the second picture, you can clearly see anotia or microtia or malformation of the ear and failure to develop. And then here is showing an epibulbar dermoid, which is one of the classic eye findings. So Faciloscapulohumeral muscular dystrophy is another condition associated with facial paralysis. And this typically presents before the age of 20 years, the facial weakness presents, and then progresses to weakness of the shoulder girdle. So even though it says presenting before the age of 20 years, I've seen patients who thought they had congenital facial paralysis, and it occurred very early on their facial weakness, and then it turns out through molecular testing they actually have FSHD. So, but typically the facial paralysis starts, sometimes they note difficulty in whistling and other movements, and then as it progresses, then the shoulders become involved, and there's difficulty raising the arms above the head. The severity is highly variable. Some only report having the facial paralysis as well and don't report shoulder weakness. It's an autosomal dominant condition, meaning again there's parent-to-child transmission, and this is caused by a mutation or change in the double homeobox containing gene termed DUX4. And so this gene lines on chromosome 4, and in the gene there's a region that's a repeat, a macrosatellite repeat part of the gene. So normally, in normal copies of this gene, there's between 11 and 100 repeat units, but the symptoms of FSHD are caused by, at least 95% of individuals, are caused by a decrease in those number of repeat units, so between 1 and 10 repeat units. So molecular testing in this condition measures those numbers of the repeat units in that gene. So lastly, I wanted to speak a little bit about asymmetric crying facies, or ACF. And so this is a congenital anomaly caused by agenesis or hypoplasia of the depressor anguli oris muscle, which is one of the muscles that moves the lower lip. And so usually at birth, when the infant cries, there's notable significant unilateral depression of the lower lip. And when the child isn't crying, the appearance is symmetric. and it most often affects the left side about 80% of the time. And it's been noted to also occur with congenital heart disease, and in that form it's termed Kaler cardiofacial syndrome. And many of those patients are found to have the 22q11.2 deletion syndrome, which is more commonly known as DiGeorge syndrome, which can also have cleft palate and endocrine issues. So that was a summary of some of the genetic syndromes that we are aware of that are associated with congenital facial paralysis. For isolated congenital facial paralysis, again, we're still learning about the genetics. Not much is known. And so it's been a focus of mine for a while to study, to further study the genetics of these conditions. So currently I'm using targeted next generation sequencing to study the genetics of congenital facial paralysis. And I'm doing this under the guidance of my mentor, Dr. Eric Schatt, who's the chair of our Department of Genetics and Genomic Sciences here at Mount Sinai. And he's also the director of our ICON Institute for Genomics and Multiscale Biology. I'm also doing this in collaboration with Dr. Jabs. And our hypothesis is that congenital facial paralysis is a heterogeneous condition, meaning that not all cases of congenital facial paralysis are exactly alike, and the genetic etiologies of developmental congenital facial paralysis remain to be elucidated. And so the objective is to identify novel disease-causing genes or mutations for congenital facial paralysis by using next-generation sequencing technologies in a candidate gene approach. So I'll talk a little bit more about what I'm doing here at Mount Sinai right now. So what is next-generation sequencing, or NGS? So next-generation sequencing is a term used to describe the newer sequencing technologies that are available that utilize a different methodology compared to the traditional capillary electrophoresis-based or Sanger sequencing. So both sequencing technologies allow you to read the sequence or bases of DNA, but Sanger sequencing is low throughput, and basically one sequence is read per capillary. So one capillary, one reaction, you read one sequence, and you read the bases or the sequence of the DNA nucleotide at a time. Next generation sequencing, for which Illumina is an example, is a high throughput method of sequencing. And so in this method, DNA is fragmented and an adapter is added, and then the template is mobilized and spatially separated. And many sequencing reactions occur at once, and you can get 10 to the 6 reads per array. So basically just a whole lot more information much quicker. So the graph on the right is showing the markedly decreasing costs of sequencing. You can see Moore's Law's observation that the computer power $1 can buy doubles every 18 months, and sequencing is becoming more affordable right here, dropping down the price at a rate faster than Moore's Law. And with this technology, we can now sequence an entire genome in days, and the price is approaching only $1,000. So what I'm doing is I'm sequencing a panel of candidate genes. And so I developed a panel of 436 genes that I thought I would want to sequence because I thought, well, maybe when they're changed, they might cause facial paralysis. And this panel included 3 known disease-causing genes, the HOXB1, TUB3, and CHD7 for Char syndrome, which I spoke about previously, and an additional 55 candidate genes from the literature, and 66 genes that are internal or unpublished candidates, and those are mainly from persons who had chromosomal microarray abnormalities, meaning there was a finding on the array in a person that was suspicious in a person with facial paralysis, and so those genes that are located in that region of copy number variation were included on our candidate gene panel. I've also included 330 genes differentially expressed in the rhombencephalon, and a lot of these genes came from, a paper by Dr. David Chambers. And basically what he did is he microdissected individual rhombomeres and then did transcriptome analysis. And basically, if we can see genes that are expressed in different rhombomeres or differentially expressed at the time that the facial nerve is developing, We know that, for example, genes are expressed in rhombomer 4 at, say, about 13 days post-coitus in mouse are important, but likely some of those genes are important for facial nerve development because they lead to the facial nerve being generated. So looking at those genes that are differentially expressed in the different rhombomeres, maybe some of those genes are actually very important to facial nerve development, and when they're altered, they cause facial weakness. And so those are some of the genes that I'm narrowing in on. So the study workflow, so how is this project set up? Basically, I'm enrolling participants, and so persons with congenital facial paralysis, and also unaffected family members and other affected family members, if that's present. The families with 2 or more persons affected, are very helpful in this sort of analysis. And to enroll them, we basically need a sample for DNA isolation, and that can be either a saliva collection kit that's easily mailed or a blood sample. And then we do basically what's called a custom capture library prep, where we're capturing the sequence of DNA that we want to sequence, and then we do the sequencing, and then you get a file that you basically need to align that sequence data to our reference genome and look at the variation from the reference. And then we sort that variation, term variance. I sort that within a program called Ingenuity Variant Analysis. And then variants are highly suspicious, confirmed by the traditional method of sequencing, Sanger sequencing, and then do segregation studies. And for suspected novel genes, then we do functional studies to prove that actually that change in the protein or that change in the gene actually does have an effect on that protein's function. So Illumina Sequencing, here's a picture of our Mount Sinai Genomics core facility. And so this is just one of the rooms, but our core facility houses 5 Illumina HiSeq instruments, and each of these are like $740,000. And so we're very fortunate to be able to have this set up here at Mount Sinai, where our sequencing is done literally just down the hall from my lab. And so the data generated here, we then run through an in-house GATK-based pipeline, and variants are filtered with Ingenuity. So summary of results today. So far we have sequenced back from 98 probands or affected persons with congenital facial paralysis, and those include persons with isolated facial paralysis or persons with a diagnosis of Moebius syndrome. So when we sequenced these persons, we identified 21,830 variants in 521 genes. Excuse me. So a variant is a change in the sequence that's different from the reference genome. We then filter these variants based on confidence, which basically means like how much do we believe that that called variant is real or true. And when we did that, we see 18,674 variants of 521 genes. We then screen them based on frequency. So ideally, if we're studying a rare disease, if a change is very common in the population, that change is likely not going to be associated with facial paralysis. So we screen based on frequency, and here I'm excluding variants with frequencies greater than 0.5% in the 1,000 Genomes Project or the NHLBI ESP exome. So if a variant is seen more frequent than in 1 in 200 persons, it's excluded. And so after that step, there's 7,381 variants and 503 genes. The final filtering strategy is to filter based on those that are predicted deleterious. So not all changes or not all variants are equal. So some variants are what we call synonymous, meaning there's a change in the nucleotide, but it doesn't change that part of the protein or the amino acid. Others are thought to be deleterious, meaning that they will have a functional, or they're expected to have a functional impact on the protein. So when we filter for keeping only variants that cause frame shift or missense, which means a change in amino acid changes or a splice site loss, we were left with 305 variants in 174 genes. So 2 persons were identified with the E14K TEB3 syndrome, and so that was their diagnosis. And 1 person was identified with a novel frame shift change in CHD7, so even though they enrolled and didn't think they had a diagnosis of Chart syndrome, likely Chart syndrome is their diagnosis. And we're currently proceeding with functional studies to evaluate variants of highest interest, some of these in the 305 list, with the aim to provide functional evidence that these are new disease-causing genes. So that work is ongoing. I'm also collaborating, or I'm part of a collaborative study with investigators from Mount Sinai, Harvard, and the NIH for a study focusing on learning more about the genetics of Moebius syndrome. And so this study includes detailed physical examination and imaging to be completed at the NIH Clinical Center in Bethesda, Maryland, and whole exome sequencing, where the aim is to sequence all 25,000 or so genes that we have in our genome to see if we can identify the causative genetic changes. And the contact person for the study is Carol Van Ryzen, a nurse practitioner at the NIH. So I'd like to thank you for your attention. For the work at Mount Sinai, I've done this work under the mentorship of Dr. Schatt and in collaboration with our Mount Sinai Congenital Facial Paralysis working team that includes Dr. Jabs, Dr. Rucker, Dr. Frimpong, Dr. Nadich, and with the help of our genomics core facility. Also, I collaborate with a physician geneticist that used to be here at Mount Sinai, is now in Freiburg in Germany, Dr. Harold Gasper, and with Dr. Chambers, King's College in London. And I'd like to thank some support that I've received from the Slomo and Cindy Sylvian Foundation. Also, the Icahn School of Medicine is a support of this work, as well as the Moebius Syndrome Foundation, and now the Facial Paralysis and Bell's Palsy Foundation. And this is my contact information. So I'd be happy to answer any questions that you may have.
Thank you, Dr. Webb, for your presentation today. That was very informative to many of us. I will ask you a few questions that we've had come in. Mm-hmm. I guess the first general one is why try to figure out the genetics of facial paralysis? What benefit is of that to those of us with congenital paralysis?
So I think one of the main benefits of understanding or identifying the genetic etiology is so that recurrence risk can be determined, either for the parents if they have an affected child with facial paralysis, or for the person who's affected and for family planning of their own. Some persons may be worried that they're going to pass it on to their children or be concerned about that. And some persons may not need to worry, for example, if it's a recessive condition. Other times it's helpful sometimes for our families because they can be prepared or to even have an early diagnosis, maybe even during the pregnancy, just for preparation's sake. So I would think that would be one reason. A second reason is that sometimes when we get a genetic diagnosis, we're able to know more about other possible associated features. For example, for a person with, say, TEB3 syndrome, the E14K syndrome, if they were diagnosed as an infant or newborn as having that change, we may know that there's higher incidence of developmental delay in persons with that syndrome. So we might know to start earlier with earlier intervention therapies or give additional treatments earlier so that the person's full maximal potential can be reached. And then I think a third reason to why we should learn about the genetics of facial paralysis or to better understand this condition is that understanding the pathophysiology of the condition or understanding why a change in a particular gene leading a change to a particular protein actually causes a particular symptoms, this information provides the foundation for future treatments. Basically, once we understand the developmental change that gives rise to the condition, we could start to think about the development of molecular therapies or other treatments in the future to maybe treat this condition.
So there are possibly on the horizon some treatments that could be coming that would help people before it's even diagnosed or even to be treated more, to be treated earlier, I guess.
So congenital facial paralysis is tricky in that I think the best, so there aren't molecular therapies readily available now. We're not there yet. But I think because we know when the facial nerve is developing and it's developing so early on, ideally, when you think about the future and maybe future possible molecular therapies, you would want to ideally treat the person when they're still in utero. And so that's another complication for this condition. But again, we need to understand, the basic pathophysiology of the condition to even get to that point where we can start figuring out treatment options other than, the options that I think everyone with the Euro Foundation has probably already heard about, meaning the smile surgeries and those sorts of options.
Okay, thank you. I do have a couple mothers of children with congenital facial paralysis, and in general they're asking when exactly during their pregnancy were the facial nerves forming and what could have been, besides genetics itself, might have caused, like they were asking me when what would cause the arteries to be restricted early in the face, that they're asking like what might have caused their child to have facial paralysis.
Yeah, so we're still learning, but again, so we are aware of persons who are mothers who took cocaine, which cocaine is known to cause vasoconstriction, meaning, which can give a blockage of blood or reduced blood to the fetus. And so we know that facial paralysis or Moebius syndrome has been associated with cocaine usage. We're still learning, sometimes there can just be vascular disruption or random different environmental causes, and we're still learning more about that.
Okay.
So what we're still learning is basically, but at the same time, like if a mother has had no known exposures, like no medications, no illicit drug use, I would like to stress that it's definitely not the mother's fault that facial paralysis happens. Sometimes things just happen by chance and we don't understand fully why it happens sometimes.
Okay, thank you. One other question was, do you know how often Moebius syndrome is inherited in children?
Yeah, so it's going to be difficult to say until we figure out these genes. So we have multiple families, I would say over 10 families, where more than 2 persons are affected with Moebius syndrome. And we're doing, the sequencing, my panel sequencing, and also whole exome sequencing, and we're trying to figure out the genes that are responsible. So clearly in those families, with the multiple persons affected, you would think that there's a clear, genetic predisposition or genetic cause. Once we identify more of those genes, then we can look in the sporadic cases, the cases where there's only one person or a singleton person, is a term that geneticists use. When there's only one person affected in the family, then we can look in those families and screen those families and say, what is the incidence of a change in these causative genes? And once we do that, then we could get a good number for you. But the short answer is we don't have a good number right now.
Okay, thank you. Let me just ask you one last question about your research project. I know you are actively still enrolling people in the research study, so just tell us, maybe reiterate a little bit how you'd like them to contact you if they definitely are, have themselves or family members with congenital paralysis.
So perfect. So I would definitely be interested in enrolling more participants. So anybody with facial paralysis that was present at birth, not just Moebius syndrome, but even isolated congenital facial paralysis, I'm very interested in enrolling them. And so if they're interested in participating. So to hear more about the study, if they could either email me, my contact information is right there, or give me a call. That's my direct phone number. And basically the process would be talking about the study over the phone, and then I'd be sending you a consent form, and we'd go over the consent form together. And for those that are far away, I can mail saliva collection kits so that persons basically collect saliva in their homes, and it's stable, and they're able to mail via the regular mail those samples, back to me for DNA isolation.
Okay, great, great. I appreciate the time you spent with us today, and I hope this has been helpful for many people with an interest in congenital facial paralysis. And I encourage you to keep on in your work, and we will definitely have you back again for some more information. And your email definitely is up on the screen right now. If anyone has some more specific questions, then feel free to contact Dr. Webb directly, or you can also contact us through the foundation. This webinar will be probably within the next week. Will be up on our website for replay, so feel free to watch it again. And thank you so, Dr. Webb, for being with us today.
No, thank you for having me.
Okay, this webinar is now concluded. Thank you.